Viveka, he has been the most consistent friend and companion of the forum. Without wasting time, I'll just ask Dr. Viveka to do his presentation on newer technologies like TAVI and MESA, etc.
So good evening, friends. At the outset, I must thank all of you for being here. I'm from Chauhan, and a special thanks to Manoj and Rahul. Yes, Rahul. So, Rahul is a name for disaster, but it's good. So, I was told to speak on, so it was again more of a salvage operation. Dr. Chauhan called me that probably somebody has ditched him again. And I think 4 or 5 times in a year people ditch him.
सर पर वो 4-5 बार आपको सुनने का मौका मिल जाता है.
Yeah, so I had to pitch in. So I think excuse for this pitch salvage therapy was that what are the things which we can do without opening the chest, so things can be done under local anesthesia. So this first slide in fact sums up the things that we can change the valve without opening the chest under local anesthesia, which is called TAVI or TAVO procedure. We can repair the leaking mitral valve, which is called mitral clip. Sometimes if the patient has got a heart blocks or heart rate is very slow, we can put in a leadless pacemaker, which is called MICRA, which is again a revolution. And those patients who do not really get on atrial fibrillation, the anticoagulation and all, there we can put a appendage occlusion device so that the stroke does not happen. So basically, we were trying to catch up with the cardiac surgeon without opening the chest, and that has put them in a spot. So if you look at the evolution of interventional cardiology, there it has been a clear request and the desire of the patients also and the treating physician that you do things at a very, very low risk where you don't have to put them on general anesthesia, because one of the biggest determinants, as Dr. Tushar would say, and he'll speak on this, that the anesthetic, so anything which you do under general anesthesia, the risk of anesthesia in itself adds on to the risk of the procedure. So we have gone in an era where we do change the valve under local anesthesia, and we have made it a day-care TAVI procedure where the patient after 12 hours can go home, and we have been doing, and you imagine a valve replacement of aortic valve or the E2 mitral valve surgery used to take a patient to be there for 3-4 hours or 5 hours surgery and then be in hospital for almost a week or 10 days, and here the patient goes home after 24 hours or 12 hours in given case. So if you look at the basic difference between the two procedures, this is what the difference this diagram shows, that this is where you open the chest and remove the aortic valve, but here in TAVI procedure what we do is that on the under local anesthesia, while talking to the patient from right groin or left groin, we go in and change the valve. It takes, now it will take less than an hour, 40-45 minutes to change the valve. We know that in mitral valve interventions, the rheumatic heart disease, if the valve has become really severely narrowed, it is a standard procedure where you can balloon the valve and it remains open for a very long time. And this is called balloon mitral valvotomy, and this has really replaced the what we call closed mitral commissurotomy, CMV. So CMV used to be standard of care, almost 3 decades back, but now nobody, even the surgeons have forgotten how to do CMV, because the balloon mitral valvotomy is something which is really, become standard of care now. So if we look at what we do in balloon mitral valvotomy, from the right or left femoral vein, we go right into the heart, and this is how we do the interatrial septal puncture. So this is the septal puncture, and because the cavitars are fused, so you just go in and dilate a balloon, which is we measure with the height of the patient and the valve structure, and after loading, this remains open for many decades, and in fact, 1/3 of the patient will not need any other procedure in lifetime. Now there was a challenge that lot of patient would come to us and they would say that there is a leakage in the valve, but they are at a high risk. The elderly patients, 75, 80 plus, or there are a lot of patients who would be having severe leakage in the valve and the ejection fraction is low. So if you do, and especially those patients who had previously had a open heart surgery and then again had a mitral regurgitation, so we clip the valve. So this is the jet of the valve. This is the blue jet is the mitral valve leakage. So without opening the chest, we can go and clip the valve. So this is the anterior and posterior mitral leaflet. So we, under the fluoroscopy and transesophageal guidance, we clip the valve and the leakage disappears completely. So this is again one of the our patient where the 3D echocardiogram is done, and it is very, very essential to get it done under the echo guidance. So this is the what we call mitra clip procedure. So now we have got mitra clip generation 4 clips, where under without opening the chest, under transesophageal guidance we go in, and this is the leaking valve. So this is again a cartoon representation. You can see the valve leakage here, but imagine if the patient, and this is the console of mitra clip. So this structure has to go all the way from the radial septum. So again, like a balloon mitral valve, what we go from the right femoral vein, and then this is a transseptal puncture. So we puncture the transseptal and then go into the left atrial side, and again then on this railroad we take the clip. So mitra clip is delivered here, and then the echocardiographer guides us that this is the structure which is the redundant. You can see this is the part of the anterior mitral leaflet which is redundant, and because of that there is a leakage to the valve. So you need to position it accurately, and then we open it and partially we clip in, and then see whether the leakage in the valve has gone off or not. So and the advantage is that you are doing it under transesophageal echo, so you know whether what was done. So you can see the torrential mitral regurgitation, and it has. So just a couple of days back, I had a patient from Odisha. Again, her son was a planning commission vice chairman, and she was high risk because of the age, and ejection fraction was normal, very symptomatic, had intermittent atrial fibrillation. So this is what we did under transesophageal guidance. We clip the valve, and you can see that you are not seeing any jet. So once we see that the jet has gone off completely, and we do some drug test and see that the clip is fairly in place and there is no leakage. So this is the point where you can see under transesophageal guidance there is no leakage. So we deploy the clip. So what we could do is that detach the clip. So the deployment is done, and this is how the clip will deploy. There is no leakage in the valve, and the patient is cured for life. Whereas in surgery, you have very few, 4 or 5 surgeons in the country who would be able to do a fairly accurate job, and that too at a very, very high risk under general anesthesia. So patient will take time. So this is what we do. It's a 3D echocardiogram under the guidance we do, and this is, the clip would look like under, in echocardiogram. But sometimes if the patient has got mitral valve replacement with the tissue valve, so remember there are a lot of patients who will be having, tissue valve implanted, and then especially in females with the reproductive age group, and after 15-20 years the valve degenerates because maximum longevity of this tissue valve would be now 15-20 years. So there we do valve with valve. So there, again we do a transesophageal echo, and under this transesophageal guidance we can change the mitral valve, and this is also, but for that we need to really do an echocardiogram. So this is the CT coronary, cardiac CT, whereby we plan the sizing and we look at the appropriate parameters, and after that this is the peri-procedure transesophageal echo. So you can see that it's a severely narrowed degenerative old prosthetic mitral valve. So here you can see a fluoroscopic picture where we have gone in transseptal puncture, and then we have gone to the left atrium. This is the old degenerated tissue valve, So what we do is that we, under a deflectable catheter, we go into the valve, enter into the left ventricle, and through this we dilate the valve and create a space within the inflated balloon. And then once we have created this space, we take the valve, and this is how it will look like. So this is the passage of the new valve into the old valve. So you imagine, this was few years back, it was just not, one could not imagine that this is possible without opening the chest. And one of the reasons, of what we say that people who have a high risk for any surgical procedure is that redo open heart surgery is a very, very high risk procedure because there is a lot of adhesions and all. So, however, accomplished surgeon is, the risk is high. You can remember when our ex-Prime Minister Dr. Manmohan Singh had a redo bypass surgery. There was a lot of noise, media that is redo open heart surgery is possible or not. So this is the valve which was deployed, and can you imagine that after 12 hours the patient was sent home. So this is the beauty of this procedure. So this is the new valve. So we call it valve-in-valve procedure. So this is how we do at the mitral valve. In naive valves where the patient had no operation done, we can put a new valve. So these are the various kind of valve which is available, but still not yet approved commercially because it's still under investigation. Coming to the aortic valve, it's a standard of care now. There, what we do is that any patient who is having high surgical risk of changing the valve, we either go from the right groin, left groin, or we can go from the left subclavian or the direct aortic puncture and change the valve. So basically, there are two types of valves. One is self-expandable valve. The other is balloon expandable valve. 95% of the time, both of them would work equally good. But like when we are treating aortic side with a new valve, valve-in-valve, and most of the time it is the self-expanding valve which is much better. So that is, the self-expanding valve, this is how we deploy it. And sometimes if the patient has got a old tissue valve, we, like I showed in the last video, that we can do a valve-in-valve with another valve in the same place. And this is something where the risk is significantly less. Patient can be discharged in daycare. In patient who has got atrial appendix, is the closure indication. We do a Watchman device closure for some patients who have got atrial fibrillation. So as we start aging, a lot of us would be having atrial fibrillation, which is the commonest cause of stroke. You can imagine that you give the patient anticoagulation or even the newer anticoagulant NOACs. The patient, if has a bleeding or cerebral hemorrhage, then you can't really give it. But they are at an increased risk of thrombotic stroke. So in that case, we put a atrial appendix closer because 98% of the clot would form right into the left atrial appendix. So we close it with the what we call Watchman device, and the patient will not have any this thing. Even in pulmonary space, those patients who have had in childhood for tetralogy or valve, you must be knowing the surgery. But in adulthood, a lot of them would have severe disease of the pulmonary valve, especially pulmonary regurgitation. But doing a surgery, redo surgery for pulmonary regurgitation would put them at a risk of around 10 to 12% mortality. But here with the Melody valve, we can implant the valve percutaneously, and the patient can, under local anesthesia, again the patient can go home next day, whereas in surgical procedure it will be very high risk. The other thing which we have not really been able to conquer is the tricuspid valve space because of its complex anatomy. But in these situations, what we do is that now we have got access to trich valve, which is a bicable valve. Reason being, it is called bicable that one valve is placed into the superior vena cava, another in the inferior vena cava, and so this is again done under local anesthesia. Hardly takes 40-45 minutes. So this is the place superior vena cava. We put one valve and the other valve is the inferior vena cava. So you are outsmarting the disease itself because you are not allowing the regurgitation into the systemic circulation. This is one of our international patient who had a couple of surgeries before. There we have implanted the SVC thing, and this is the IVC arm of the valve. And end of the day, this is how it would look like, that the patient has got a deployed SVC arm and the IVC arm, where the patient would be doing fine. So a lot of patients would have, what we call conduction system disorder or sinus pauses and all. and they don't have venous access. So in those situations, we put leadless pacemaker to give the support. So remember, almost 3 to 5% of the patients who need aortic valve surgery or TAVI procedure, they might need, because of the conduction system disorder, they might need pacemaker. In that case, just to make the procedure simple, we can implant a leadless pacemaker or migra where the reduction can go on there. And the advantage of this is that the complication rates are 52% lesser because you don't have any pocket, you don't have any leads. So those lead and pocket related complications will be significantly lesser. And on our X-ray or fluoroscopy, this is how a leadless pacemaker would look like. So I think this is one of the patients who have had a severe aortic stenosis. So he happened to be 87-year-old, professor of dermatology who was our teacher in PHU. And so he was well read, 87, but fit and was doing his practice in, I think, the hood. No. And so he said that, I want to continue the practice. I don't want to take even 0.1% chance of cerebral stroke. So we put a sentinel device here to cut, what we call cerebral protection, and then we implanted this valve, and this valve was implanted here. This is the implantation of the valve. This is a self-expanding valve from the Medtronic company, and after implantation of the valve, he's doing, so he's still 1 year down the line, he's doing absolutely fine, continuing his practice as well. So then we remove the sentinel device, cerebral protection device, and so to conclude, I would say, so this was just glimpse of what all can be done percutaneously in this case of the valve. So with the absorbable stent, TAVI procedure, microclip, Watchman device, and lead-based pacemaker, we can send the patient, even most complex of the complex patients, because once upon a time heart surgery was considered to be a very, very big thing, but now it can be performed with local anesthesia and with really no complications at all, very, very acceptable range of complication. And this has really made the job of the patient and life of the patient secure, and our job also very good. Thank you very much for your attention.
Thank you, Dr. Viveka. Can you just join me out here on the desk?
So that was the promise which I
thank you so very much for elaborating on the the way that newer technologies in interventional cardiology have evolved and have.
I'll take one or two questions if there is.
Yeah. So I'm just about to that.
Dr. Tushar.
That's what I wanted to say. Dr.
Light jala देना, light.
With me, since I would be the bacha, his student. So, but I will not be answering the questions since Dr. Viveka is here. So I will be asking the audience in sequence to ask relevant questions to Dr. Viveka since he has to move, and Dr. Kalra and Dr. Tulsi.
Just to start.
Lights and
Light, action and camera. That's a method.
Sir, half question. Sir, as you say, bypass surgery was the bigger thing. Now you have bypassed the surgery itself.
Yeah, so this is bypass.
You are bypassing the surgery and making it non-invasively the same thing as the surgery would have done. Thank you so much.
Let me say that was again a fantastic talk, Dr. Viveka. So, balloon expandable versus self-expanding, which is better, sir?
No, so I think 9 out of 10 cases, balloon expandable or self-expandable, it will be same. So there are certain anatomies like, the patients who have got already, if you are doing valve in aortic space, then we need to prefer self-expanding because that will give a bigger space, so valve size is bigger. And also in self-expanding because inherently when we are implanting 26 valve with balloon expandable, we can go to 29. So the risk of recurrence or re-stenosis is significantly lesser, meaning thereby the longevity of these valves are significantly higher in self-expanding. So we try and do, but at the cost of increased rate of pacemaker implantation. So if you see the anatomy, most of the patients would fit in both. So whatever their pocket can allow, we can, or the operator is comfortable with, we can offer them that.
Sir, what about in low-risk patients? See, we know it is indicated in high-risk and moderate-risk patients, aortic stenosis. So what about in low-risk patients? So probably you do it in low-risk patients as well?
So basically,
after the Evolute trial and the partner trial has come?
So if you look at the partner 3 and Evolute, low-risk trial, after Sartavi trial, which was an intermediate, so let me clarify that when we are, use the term like low risk, it has nothing to do with the age. So for cardiology community and so fortunately one thing which is common in our specialty and Tushar's specialty, that our patients are the elderly patients. So, prostate and heart, they come together. So the patients, when we say that low risk, he can still be in the range of 75, 80 years. So when we talk about low risk, it is more of I would say surgical risk. So if the patient is non-diabetic, has got good anatomy, kidney function is fine, so those are the low risk. It means that when the surgeon does open heart surgery in these patients, the risk of mortality is less than 1%. So we call it STS score. So if the STS score is less than 4, then they are low risk. Having said that, age and frailty in itself, it cannot be quantified with the risk score. So in that situation, it's the operator's call. But coming to your question that in low risk, it is a recommendation now after the Evolute trial and the partner 3 trial, that there also the risk of complication, longevity, the stay in hospital on these scores, the TAVI procedure was superior to open heart surgery.
So what about the asymptomatic aortic stenosis? See, observe or intervene. The recent data supports early intervention. But the 2023, was it May? Yes, it was May. ESC and the ACC and the AHA guidelines said probably do our guidelines recommended the stress dopamine echo and evaluate. But recent guidelines, as recent as just about a week back, said probably you need to do early intervention in even asymptomatic aortic stenosis. Sir, about on that?
Yeah. So the reason why the asymptomatic patients were not allowed to go under the knife was that if they don't get anything done, the risk of mortality is not significantly high. So 2 years mortality was less than 0.05%. But if they go under the knife, means if they get open heart surgery to get the valve changed, so the mortality would be at least 2%, even best of the centers in the world. So the question came that what to do. So symptoms of the patients in this age group, especially those who are 70 plus, is something which is very, very tricky. So we need to take out the symptoms. The patients, as you rightly said, we should do a stress test, because a lot of these patients would feel that these symptoms are not because of the severe aortic stenosis, it could be because of his or her aging process. So you need to dig this out, and then 70% of asymptomatic severe aortic stenosis patient would turn out to be symptomatic aortic stenosis patient. Having said that, still the open heart surgery would be at a higher risk, so it was recommended that we should go for TAVI procedure where if the anatomy is suitable. So again, when we say low risk surgical case, we should also look at the risk of TAVI, whether the coronary occlusion or the femoral artery complication or access site complications. So these things, there is a very nice algorithm to decide. So if it falls into the low risk intervention group, then all the the asymptomatic severe aortic stenosis patients should go for TAVI procedure. That is the recommendation. Because remember, one of the first presentation of severe asymptomatic aortic stenosis patient could also be sudden cardiac death. So that is why we are concerned that they should be treated in a procedure which carries a very low risk.
Finally, a word on the BBS. Are they coming back after a long and protracted demise?
Yeah, so they have already come back. So BVS is in current use and we are using it, but it's only globally available from a couple of companies. So in India, it is Narain Life Sciences which is making. So it has a very niche use. So patients who are very young, those who have got good artery size, there we can use, but not in all comers.
Thank you, sir.
Thank you very much, and sorry for getting into Dr. Tushar's time. So Amish Shora, good friend. Yeah.
Two short questions, sir. A lot of family and friends, when they have anything to do with valve stenosis, I see a lot of non-cardiologists writing, kindly consider TAVR or TAVI, whatever. What are the absolute contraindications of TAVI and TAVR, irrespective of the risk status? That is one. And second is, what are the indications for leadless pacemaker for people, non-cardiology people like me?
Yeah, so I consider you as a non-cardiologist. So if you see the absolute contraindication, so there are two: social contraindication and medical contraindication. So so today I had a patient who had a vegetation on the leaflet. So obviously this is not a candidate. So absolute contraindication is infective endocarditis or active infection. But others are relative contraindications. So remember, we started with severe aortic stenosis, but now we can do in bicuspid aortic stenosis also. Now we have started doing it, and with good success in severe aortic regurgitation. So it was off-label use in regurgitation, and then it was said that in rheumatic heart disease we should not do. I have got a series of 15-20 cases which we have published also, and that was well received. So the absolute contraindication to me, it looks like that if the anatomy does not allow you, it means that so there is hardly any anatomy which is not suitable now, because we can go from if the arteries are not suitable, we do what we call IVC, inferior vena cava route, where we go from the femoral vein, enter from the inferior vena cava to aorta, wherever the disease be, and then go all the way into the. So absolute contraindication is active infective endocarditis. That's the only contraindication. And then the leadless pacemaker is something where any patients who is now, we have got dual chamber leadless pacemaker also. So the social contraindication is obviously if the pocket doesn't allow, you can't really get it done. So the cost is still it's come down almost 50% with Indian valves, Narain Life Sciences and all, but that in reality is still hell of a lot. So almost 15 lakh rupees would be there. So that's a cost. And same is with the leadless pacemaker. So if the patient can afford this, a wonderful thing. And I would say that in leadless pacemaker, I would have discharged almost 50-60 patients in 12 hours. So that's the advantage is that something where you don't, the risk of complication of the pocket infection, leads and all those things is not there. But obviously the cost is an issue. So again, in leadless pacemaker, the commonest indication is that the patient who had a previous pacemaker got infected, there is no access, then you can go from the either in an internal jugular vein or from the femoral vein and implant it. So that's a wonderful technology, I would say. Thank you.
So thank you, Dr. Viveka, for summing it up so beautifully. I believe you have to leave, so
Yes, so I will not go that side.
So one thing Dr. Chauhan sir said, I mean my qualifications don't percolate over to like Dr. Karoli's prescription, because the backside of Dr. Karoli's prescriptions are more to do with medical details.
Thank you, Dr. Gupta. So we will start the second talk, which is role of robotics in uro-oncology. And the speaker is new to our forum, but he is a very well-renowned uro-oncosurgeon, and he is one of the rare urologists who has devoted his skill to uro-oncology surgery. At present, he is in Max Smart as senior uro-onco robotic surgeon. Earlier, he was in Medanta, and before that, he has done he was a senior clinical fellow in University College London Hospital, and before that he was assistant professor in All India Institute of Medical Science in the Department of Urology. He has dedicated training for 2 years in prostate cancer, bladder cancer and robotic surgery in London, and he has more than 50 published research papers. Area of expertise: robotic radical prostatectomy and robotic partial nephrectomy, also called nephron sparing surgery. So, Dr. Tushar, you can start your talk.
Thank you so much, sir. Respected chairpersons and Physician Forum of India, dear seniors, Dr. Viveka is left. Good evening to all of you. I'm Dr. Tushar Aditya Narain, and I'm a uro-oncologist and a robotic surgeon. I'm working as a senior consultant at Max Smart Hospital, and my field of interest and work is uro-oncology and robotic surgery. I was a trained urologist. I trained at PGI Chandigarh in my urology. After that, I was working as a faculty at AIMS. And then I moved to UK to get a specialized training in robotic surgery and specifically pelvic oncology. So my core area is prostates and bladder cancer. So today I'll just be talking briefly about prostate cancer and introducing robotic surgery to all of you. Dr. Viveka, obviously he talked about the interventional procedures, and he said surgery, as compared to surgery, these are minimally invasive. But what I am talking about, he talked about 24-hour admission. I am talking about 12 hours admission in the morning, prostate cancer, get your prostate out and go home the same evening. Daycare procedures, we were doing that in London. I'm almost on my way to get it done here. Right now our admission duration is about 48 hours, but it's not far off. That morning admissions, get your prostate out, evening discharges. So it's a daycare 12-hour procedure. So let me start off with my talk. Prostate cancer in India, why are we talking about it? Prostate cancer has been steadily rising, and you'll be surprised, in India, Delhi has the highest number of prostate cancer patients. One, or now even two, the data has come up, 2 in 10 men will have prostate cancer in their lifetime. You can see the graph, there has been a sudden surge in the prostate cancer patients after 1986. This was the year when serum PSA blood test was introduced as a screening tool. Serum PSA came in, everyone started testing their PSA levels, and there was a sudden surge. And this increase in the number of cases has been steady over the years, with Delhi topping the list. Just a brief introduction and a background about prostate cancer. How do we detect prostate cancer? Can I have the mic, please? I'll be better off with this. So how do we diagnose prostate cancer? As I said, serum PSA levels. So that is a simple screening test. You do a PSA blood test, the PSA is high, and you are referred for further tests. Preferably you are referred to a urologist. So what's the next step when you get a high PSA? The next is a multi-parametric MRI, which is specific for prostate. The multi-parametric MRI is so specific that even a 1 millimeter lesion in the prostate can be picked up on the MRI. Once you've got an MRI done, the MRI gives you a scoring. The scoring is from 1 to 5. 1 and 2 are benign, 3 is equivocal. Sorry. No, I don't need it, thanks, that should be fine. That should be fine, I'll be fine. And 4 and 5 are malignant. So if it's 4 and 5, you have to go in for a biopsy of the prostate. So, which one? This one? Yeah, okay. Yeah. So 4 and 5 is malignant. If your MRI says it's 4 and 5, the next step is a TRUS-guided, which is transrectal ultrasound-guided biopsy, or a MR fusion biopsy. This is a recent introduction wherein the MR images of the prostate lesion are fused with the ultrasound machine, and the MRI tells us where to target that lesion. And once all of this is done, the final step is a PSMA PET to see if the cancer is localized to the prostate or it's spread to other parts of the body. So this slide will just tell you in detail and the whole totality how to diagnose prostate cancer. PSA, MRI, biopsy, and a PSMA PET. So now, if the prostate cancer is localized to the prostate, what treatment options do we have? Surgery is the preferred modality of treatment. If a patient is not fit for surgery or he doesn't prefer surgery, we also have hormone therapy and radiotherapy as a radical treatment. Now coming to surgery, I'm a surgeon, I'll talk about surgery. What are the options? Open surgery, laparoscopic surgery, and robotic surgery. These are the 3 options that we have for prostate cancer, which is localized to the prostate. This is a snapshot from Campbell Walsh textbook of urology, which is considered the Bible of urology. The first line says, there is no better way to cure cancer that is confined to the prostate than surgical removal. Surgery is the best form of treatment for localized prostate cancer. You go on to the next paragraph and it says, technically, radical retropubic prostatectomy, that is the traditional open prostatectomy, is one of the most difficult surgeries in the field of urology. Believe you me, I have till today done only 2 open prostatectomies, and I don't think I'll ever do an open prostatectomy. It is the most difficult surgery that I've ever done. I had a blood loss of about 2 liters, which is not just mine, it is the average blood loss, and the patient was in ICU for 3 days. It's that difficult. Then came in robotic surgery, and there have been several trials. I've just shown 2 which have compared robotic to open surgery, and now robotic surgery is the gold standard for prostatectomies. You have prostate cancer, you have localized disease, you want to get your prostate out, there is no doubt robotic surgery is the way to go forward. The era of open surgery has gone. These are the different papers. There are 2 major side effects of surgery. That's one is urinary incontinence, the second is erectile dysfunction. And this has been compared between robotic and open procedures, and robotic has been shown to be far superior than open procedure for all of this. So now coming to the robotic surgery, this is a famous picture from Tushar Aditya. Tushar was the father of surgery, father of plastic surgery, and in his book, the Tushar Aditya, this is a real cover of his book, which was published in 1907. The first page says, a great surgeon is one who possesses courage and presence of mind, a hand free from perspiration, a tremorless grip of sharp and good instruments, and who carries his operations to the success and advantage of his patient who has entrusted his life to the surgeon. All of these teachings can never be true with the open surgery, but all of this has been true now with the robotic surgery. The tremorless hands of the surgeon has been replaced by the instruments of the robot. And I'll show you how all this is true with the robotic surgery. Again, this is a very famous painting called the Vitruvian Man. Leonardo da Vinci is the painter, and he was known for making the most accurate depictions of the human anatomy. In this picture, there are 2 images of a naked man standing inside a circle and standing inside a square. And this is considered as the most perfect amalgamation of science and art. So taking inspiration from this, there's a company in US called the Intuitive. They were the first company to make the robot, and they named it the Da Vinci robot, which is the most widely available robot all over the world. I'll just take you through a brief journey of how the robot evolved. The first robot in the US was produced in 1999. This robot didn't come to India. The second generation robot, which is this one, this is called the Da Vinci S. This is the robot which came to India in 2006 at All India Institute of Medical Sciences. So this was the first robot that came to India. Then in 2009, they again came with the 3rd generation model, which is the Da Vinci SI. This robot is at present at AIIMS New Delhi. This is at Vedanta. In 2014, they made further modifications, and they came up with their best ever model, which is called Da Vinci XI. And in 2017, they came up with something called as Da Vinci S. Da Vinci S is between SI and X. When they created XI, they created something very good, and they realized for the Indian market, they don't need something very good because it was very expensive. So to cut down the cost, they went back and made something between these two. This is 2017. So just to give you an example, this is the Mercedes C-Class, this is the Mercedes Maybach, and this is the Mercedes E-Class, which is between these two. To give you a perspective, Max Saket has 2 of these XIs and 2 of these SIs. We have 4 robots in that Max Saket complex. So this is the Da Vinci XI, which is the best model that they've created. This is the robot that I use at Max Saket. Now there are other companies that have come in. Till about 2 years ago, Da Vinci had a patent of about 20 years that no other company could produce the robot. But now that patent has expired. This is CMR Surgicals, which stands for Cambridge Medical Robots in Cambridge. They have created another robot which is called the Vercius robot, which is almost similar to the Da Vinci but not as good. This is another, This is another robot from Medtronic company. It is called the Hugo Ras. This also is on the same principle, almost similar, but not as good as the Da Vinci. So this is like Mercedes, Audi, and BMW. Now comes the game changer. This is the Mantra robot, which is a made in India robot. It is produced by SS Innovations, led by a cardiac surgeon. So this is a made in India robot. And why is this a made in game changer? All the other three robots, a one-time cost of buying them is about 20 crores INR. This is 5 crores. So this is 1/4 of the cost. Make in India. All government institutions have now taken a decision to replace all the Da Vinci exercise by the SS Mantra because it's a Make in India initiative. All of these aims have a Da Vinci robot as of now. Soon they'll all be replaced by this. This is a Make in India robot, but I have personally used this robot. This is not as good as the Da Vinci, obviously. It will take some years. But this robot is now installed at Rajiv Gandhi, and they've done about 200 cases on this robot. So soon, in the next 3-4 years, every hospital, every private hospital would have this robot because of its low cost. So now, let's see how the robot works. So this is called the surgeon console. The surgeon sits here on this console. This is the eyepiece. There are two eyepieces. You put your head in, you get a 3D vision with the two eyepieces there. It's a 5 times magnified vision. And this is the joystick which I use to move the instruments which have gone inside the patient's body. So this is the surgeon console. Now this is the patient side console. These are the 4 instruments that goes inside the patient for doing the surgery. This is the SI model, which is the earlier model, which is at AIIMS New Delhi. And this is the XI model, which I am using right now, which similar 4 arms, just that the maneuverability is better. So this is called the patient side cart, which goes inside the patient. And this is another robot which we have at Max. This is the S, which I said between XI and S, with the swastiks, and this is our robot. This is another patient side cart where we have the monitor, where the assistant sees the surgery. There is an insufflator because we use carbon dioxide to blow up the tummy to get space, and there's electric cautery source there. And these are the different needles. I'll not go into the detail. Different instruments that we use inside the patient: scissors, needle holder, knives, all of that. Now let's see how actually the robot works. So this is the power on buttons. This is the patient side, the 4 arms on the robot. The video sound is not playing. That's okay. So
basically, these are the 4 ports that goes inside the patient, and the arms then dock onto the port. So on the patient, there are only 4 small holes through which we place ports, and the ports get attached to these. And then we put instruments inside this. This is the surgeon console where the surgeon sits in, sees inside, where he gets a 3D vision. I feel as if I'm sitting inside the tummy when I'm operating on the prostate.
So these are the 4 ports. This is the joystick movement, 360 degrees movement. Your hands cannot turn 360 degrees, but these instruments can turn 360 degrees. This is a needle driver, showing how the suturing is done. This is the port that is inside the patient, and the robot comes and docks onto this port like this, and the instrument and the camera goes on through this. So there are 4 arms. 1 arm is for the camera, 3 arms for the instruments that we use during the surgery. So this is the actual OR setup. This is at Max Saket. I am there at the surgeon console.
I have a bedside assistant who keeps changing the instruments, does the suction. This is a screen which I had shown for the assistant, and he puts clips, changes the instruments, because once I need a scissor, then I need a needle driver, a clip applied. So all of these is done by the surgeon, which I introduced Praveen that he does that.
Just a small clip as to how it looks inside. This would not do justice to the vision that I get inside, because this is a 2D vision, I get a 3D vision. So this is a small step of the prostate surgery that we do. We go behind the bladder. The prostate is behind the bladder.
The rectum is beneath, the bladder is up. In open surgery, there's hardly any space. You just put your hand in, there's no more space. But in this, the vision is magnified 5 times. This is the vas deferens, a small tube that carries your semen. This appears so well on the robot. In an open surgery, I've never seen the vas deferens like this. And you can dissect each and every fiber. you see a lot of red stairs. Those are almost RBCs. This surgery did not even have 10 milliliters of blood loss. So that is the vision that you get. We are behind the prostate, the rectum is beneath. We go all the way beneath the prostate up to the apex. There's hardly any space, but the instruments are so slender, less than a centimeter, that they all go inside the pelvis and we can do the surgery with that. Frankly speaking, the whole space is not even 1 centimeter inside there. Now once we have done the posterior dissection, we drop the bladder. We drop the bladder and go on top of the bladder because the prostate is sitting in front of the bladder. So that's the bladder being dropped, that's the prostate coming into view. This is the lateral pelvic wall. This is the bladder drop on the other side, inside the peritoneum. This is the scissors that I'm using. I have a retractor on the other hand. So I cut with the scissors, drop the bladder, hardly any blood loss. The vision is so good, you see each and every vessel. So obviously you see the vessel, so there's no blood loss because you coagulate before they bleed. This is the pubic bone, pubic arch like this here. All of this is being dropped down. Once the bladder has been dropped, this is the prostate that you see here. The bladder is here, prostate is here, this is the apex. We just remove the prostate from here. You see, you can appreciate the contour of the prostate here. This is the lateral pelvic wall. So this is the prostate. So that was a small, I didn't put a very big video. I have one more slide. So this is the future of surgery, which I wanted to show. This robot is called the Da Vinci SP, the Da Vinci single port. Only USA has it, nowhere in Europe or UK has this robot. What's the beauty of this robot is that all 4 instruments that I showed in goes through a single port. So you make one opening in the body, all the instruments go in and then they articulate at a distance. 2025 is when we expect this to come to India. I'm hoping Max will get this robot. So this is the ultimate robot that is available. The whole surgery is done through a 1.5 centimeter incision. The whole prostate, not even only prostate, bladder, cystectomy is a major surgery. People are doing cystectomy through this surgery. The whole bladder is out. You make a new bladder with your intestines just through a 1.5 centimeter hole in the body. So this is the Da Vinci SP, which is going to be the game changer, which we are expectantly waiting that in 2025 it should come to India.
Good.
So that's the future. And just a few slides of what we have done. We basically focus on prostate cancer. So we've removed about 250 prostate since I came to Max. And we do bladder cancer surgery, cystectomies. The whole surgery is done, bladder is out, there's IL conduit, but there's no cut, only 4 small holes through which we do the surgery. So radical cystectomy, prostatectomy, kidney surgeries, partial nephrectomy. This is an adrenal tumor, 10 centimeter adrenal tumor. Patient was discharged the next day with less than 50 ml blood loss. This is something called as video endoscopic inguinal lymph node dissection. In carcinoma penis patients, inguinal lymph node dissections are needed. And the traditional way, we used to make big cuts here and there was a lot of flap necrosis, infection. Now through the 4 small holes, we do the whole surgery of inguinal lymph node dissection. So that's my team that I introduced to you, Mr. Manpreet Singh, Mr. Praveen Dati, Mr. Manish Sharma. And we are based at Max Smart and we are doing all of uro-oncology and robotic surgery. Thank you. That's another very famous painting of Leonardo da Vinci called The Last Supper.
So thank you, Dr. Tushar. Before I hand it over to an apt discussion with Dr. Podar sir and Dr. Tushar, just a small anecdotal thing that I wanted to mention. What my dad told me when he came to England to do a residency out here. Looking at the open prostatectomy, there should be a very famous surgeon, Dr. Sushant Sen, or all the old timers from Mamsi, etc. They would know. Sen Nursing Home used to be one of the biggest establishments just close to the ITO, what it is now. And Dr. Sushant Sen was a very admirable and a very handsome young man who has this nefarious reputation of running away with ambassadors' wives. But he was a brilliant surgeon. So Babu Rajendra Prasad had a prostatic problem which everybody had in the country. And Sushant Sen did that 14 minutes skin to skin in those times, an open surgery for which he got awarded a Padma Shri. So that's the history of surgical fantastic surgical expertise of people around the country who have done that. and hats off to these guys for taking technology forward. But that's what we have gone through. The seniors etc. have gone through. So this is something which is on record. And Dr. Tushar had phenomenal surgical reviews. So maybe that can be taken up at a later point in time in terms of anecdotal discussion. I hand it over to Spudar and Dr. Tushar for the brilliant.
I agree. Dr. Singh was the greatest surgeon of Delhi at that time. Dr. Tushar, you did mention per rectal examination in diagnosis. So you oncosurgeon don't give any importance to it, okay?
That is the first thing that has to be done. But if any patient coming with any symptoms, you have to put your finger into the rectum. If you don't, you put your foot into the rectum. You have to put your finger. Yes.
In Love Valley, this is written in relation to carcinoma rectum, but this is true for prostate also. In Love Valley, this is in relation to carcinoma.
My team is sitting here, they will vouch for it. Every patient that comes, they know it's not prostate cancer, PSA is normal. Still, I make the patient lie down, do a per rectal exam. You have to do it. A lot of times, PSA is normal. Put a finger and you feel a large nodule in the prostate because it can be neuroendocrine differentiation, small cell differentiation where the PSA doesn't rise. You have to do it.
So, per rectal examination should be done in all cases of prostatic and preferably before doing PSA. Because some studies say that PSA will rise after per rectal examination. Yes, Dr. Chauhan.
Sir, wonderful presentation.
Thank you.
We didn't know about such a wonderful person with such a great skill set. Many people were saying, ask Dr. Tushar Aditya Narayan not to go to Mumbai. We'll support him here only.
Thank you.
Yeah, so people are really impressed. Sir, some basic questions. You mentioned about doing the importance of doing PSA. Anything specific about PSA, total, free, index?
Yes, so I'll answer that question. That's a very good question. Because a lot of patients get confused, they get the free PSA, total PSA. What you need to do is a total PSA. You get a total PSA done. Free PSA only has value between a range of 4 to 10. If your total PSA is between 4 to 10, you go for a free PSA. And then we do something called as a ratio of free to total PSA. If that ratio is less than 0.25, only then it is important. If your PSA is 11, 12, free PSA has no meaning.
Sir, the second question which I just interacted with some of the friends, they said Dr. Tushar only does prostate, bladder and inguinal lymph nodes?
No.
Or he does the normal prostate also?
As in TURP for BPH?
Yes, sir.
I used to do, I'm trying to restrict my practice only to robotic surgery because...
Only for onco?
Only for onco.
So if I have a patient, my uncle...
Yeah, I'll do it. I've just done a stone patient and a normal non-cancer.
So you do it as a favor?
As a favor, yes. I've been trained at PGS so I can do everything, but I'm trying to restrict because I'm part of the cancer team. I'm trying to restrict my practice only to oncology, but I do everything.
So what's your favorite, Holmium laser or something else?
Holmium is the best. Holmium laser, yes.
Right. Yes. Now, suppose I had a case of prostatic cancer.
Yeah.
And sir, you did this wonderful surgery with the Da Vinci. What is the cost of surgery in your setup?
So we have packages for all of this. For a prostate, which is straightforward, 2-day stay, admission on the morning of the surgery, and discharge after 2 days. It's about, depends on whether it's insurance or what. But on an average, it's about 5.5 lakhs, which most of the insurance companies are covering completely.
So after you've done the surgery, sir, there is still this onco part to be taken care of in the follow-up.
Yes, follow. So most of my patients do not require any further treatment because obviously all the margins are negative, everything. The only thing that is required is a 3-monthly PSA follow-up. Every 3 months for the first year, PSA. Second year, every 6 months. Third year onwards, annual PSA follow-up. If the PSA by chance, after surgery, it should be negligible, less than 0.1. If the PSA by chance starts rising, then we evaluate where he has failed, whether in the local region or systemic. We do a PSMA PET, depending on that hormones or radiotherapy.
Sir, if I have a case with widespread
metastasis,
yeah. do I still refer that case to you, or I straight away send that patient to Dr.
I think he is the right person. I will still prefer you send it to me and send it to him. But yes, no, medical oncologist case. No role of surgery only if he has urinary symptoms. Then I do it called as channel QRP. I put in my scope, open the prostate so that he does not have any urinary symptoms. But for treatment, it's the medical oncologist, hormones therapy, and now obviously second line hormone therapy, abiraterone, chemotherapy, all of that. But it's the medical oncologist domain.
As my uncle, he has multiple urinary bladder diverticular.
Sure.
He got operated by an eminent neurosurgeon in West Delhi about 10 years ago.
Okay.
And
what was the surgery? Diverticulectomy?
No. The surgery was prostatectomy. He had a BPH. He had a prostate of over 78 grams, which was removed.
Okay.
Unfortunately, it seems the urinary bladder neck, the bladder neck was not taken care of, and he has got multiple diverticula, urinary bladder diverticula, and he gets recurrent UTI because of that. Sir, what is the way ahead for him?
So we'll have to see, most commonly the reason why he has multiple UTIs and diverticulitis is not emptying his bladder. His post-void residues are high. That's probably because he has developed a bladder neck contracture and narrowing and he cannot empty it. So we'll have to put a cystoscope in, see what's the reason. If it's a bladder neck contracture, open it. If it's a urethral stricture, dilate it. But we need to make sure that he's emptying his bladder completely. And recurrent UTIs and development of diverticula tells me that his bladder is pushing against a high pressure but cannot empty the bladder. So we have to take care of that. So the simple thing would be to put a scope in and see what's happening.
Sir, apart from prostate, you are also doing renal cell carcinoma?
Yeah, absolutely. Tomorrow morning, partial nephrectomy.
You did show a case.
Yeah, it would have been too long. I thought tomorrow morning I'm doing a partial nephrectomy at 8 o'clock or what.
All right. Dr. Anish Vorak, sir.
Yeah.
Excellent presentation.
Thank you, sir.
I think you are going to change the guidelines very soon, looks like. So based on those guidelines, I'll ask you two questions.
Sure.
One, recently, since you have been trained in UK also, recently, just I think 3 months back, there was a 15-year follow-up of observation versus radical prostatectomy in a low risk to intermediate risk localized prostate cancer. They saw that the overall survival at the end of 15 years, there was no change.
No change. Agreed.
But surprisingly, when I did the webinar amongst 100 medical oncologists, 97 said, "Hum chance nahi lenge, hum to surgery karwa denge."
Okay.
Even though overall survival was good.
Yeah.
But that study did not involve robotic surgeries.
No.
So do you think that with the robotic surgery coming in place, is observation going to be in vogue? That is the first question. And second question is, again, because you are trained in UK, hardly any Indian oncologists, they do life expectancy before treating prostate cancer.
Absolutely.
And it is very crystal clear written in the guidelines, if a person is expected to live less than 10 years, just do observation in a localized, would like to know your thoughts.
So it's very different in the UK, very different in India. For example, I'll give you a very small example. When I came to India, it was my first month, I was at Medanta. I had a Gleason 3+3 disease. I told the patient, you're a perfect candidate for active surveillance. You need to do a 3-monthly PSA, come to me after 6 months, I'll do a rectal exam and once a year biopsy. You don't need treatment right now. He came to me 2 weeks later and he said, you told me active surveillance. I went to another doctor, he took out my prostate. And that day I realized active surveillance observation doesn't work in India. I have 9, if there are 10 neuro-oncologists here, 9 who would say, okay, in conferences they would say active surveillance guidelines, they would remove the prostate the next day. After that I stopped telling patients active surveillance. I give them an option, but I tell them surgery is also an option for you. You can choose. I still have patients on active surveillance, but they are very learned patients, they understand what it is. But I've also given them the option of surgery because if I tell them I won't operate, someone else will operate then the next day. Complete normal activities like swimming, running in a month's time. So I think if I had a Gleason 3+3, I would rather get it out than getting a biopsy every year and being under the stress of having a prostate cancer. Open surgery was a different ballgame altogether. The incontinence rates were very high because you don't see where you're cutting the sphincter. All patients were impotent. 1,200 ml, 2,000 ml blood loss, 7 days in the hospital. So that's when all of this active surveillance all came in. If robotic surgery was there 30 years ago, probably active surveillance would not have come. That's what I think.
So, taking clue from Tulsi sir, even though I said I'll ask 2 questions, I'll ask the third question also. Sorry, sir. I think for this group also, there's always a dilemma between PSMA PET scan and multiparametric MRI.
Yes.
If you call Dr. Harsh Mahajan in Mahajan Imaging, he would say MRI.
Okay.
But if you see the papers after paper, they said even in localized de novo naive patients, your PSMA PET scan can give you enough information. Unless and until surgeon wants to ask certain further. Just as a general, what would you prefer and when would you?
So, baseline rule, if you have to see the prostate, MRI. If you have to see the whole body, PSMA PET. A lot of patients come to me, biopsy proven, PSMA PET, no mets, biopsy has disease, said do my surgery. I have to get an MRI done because the nerves on which side do I need to spare, where is the rectum close to the prostate, PSMA PET scan does not show all of that because it just lights up like a bulb. So you don't know where the rectum is, where the prostate is. For all those planes, it has to be an MRI. I cannot do a surgery without an MRI. Because on the MRI, I have to see which side nerves are involved, which nerves do I have to preserve. On the MRI, I measure the length of the urethra, which is something called as MUL, membranous urethral length. That tells me this patient will be continent in 1 week, 2 weeks, 3 months. 14 mm is considered as the cutoff for the length of the urethra. Below that, the continence gets delayed. So I have to counsel the patient accordingly. So on the MRI, I ask my radiologist to tell me what's the length of the urethra that I'm going to operate on. So all of this is required. So MRI is a must for the local.
Dr. Tushar, PSMA is better if to decide the mode of treatment.
No.
And if you decide for surgery, then MRI give you better option.
Yes,
That's what.
absolutely. So PSMA to look for disease elsewhere in the body.
If you decide
Yes.
after surgery, then you do MRI for it.
Yes, absolutely.
Sir, moving away from prostate, let's come to CA bladder.
Right.
Urinary bladder.
Yes.
Transitional cell carcinoma is still one of the most difficult malignancies in the body to treat and not a very good prognosis.
Right.
Your experience of treating CA urinary bladder in India?
It depends on the stage of the disease. So mostly in India, it's all locally advanced. People don't come, even if they have blood in urine for a year's time, they don't turn up. Only when it's bleeding so much that they have clot retention and stop urinating, do they come to the doctors. So in India, it's mostly locally advanced. Whereas in the West, even once you have blood in the urine, they go through something called as the hematuria pathway. You just have to call NHS, tell them I have blood in the urine. Next day, you have a CT scan book, you have a flexible cystoscopy book, and you have an appointment with the urologist. So these 3 things they do for any hematuria. In India, it's not done, so all of these are locally advanced. And as you said, bladder cancer is amongst all urological cancers, bladder cancer is very bad. If it's localized, T3, T4, it's not metastatic, surgery is the best way forward. Get the bladder out, make him a conduit. T3, T4, give him adjuvant chemotherapy, and he will have good survival. If it's metastatic, I am afraid I would say the median survival would not be more than 1.5 to 2 years. So would be a better person to tell me or answer that.
Dr. Thakur, Padmanabhan sir.
Sir.
Dr. Tushar, it was a very good presentation.
Thank you, sir.
I don't have any question.
Sir.
I just wanted to give you a suggestion.
Sure, sir.
Because you have been trained in UK.
Sir.
I have also been trained in UK for
Sir.
8 years in Guidance and Somerset Hospital.
Right.
System is very different here
Yes,
and there.
very different, sir. Very different.
Here you were in NHS.
Sir.
Here you are in private practice.
Absolutely.
And when you had come to Medanta,
I was a fool. No, I was a fool thinking that NHS would follow.
I'm not going to say that because my wife also works for Max.
No, between NHS and private.
You are right. The thing is, life is very different.
Very different.
Patients are taken care of in a different manner.
Right.
Here, they have to borrow the whole in their pocket. There,
Government is paying for it.
So surveillance of the what we were talking about the prostate is well taken care of. Anything, any surgery, any surgery. Yes, there is a time period for that. For OPD appointment also, you need 2 or 3 months time in NHS.
Yes.
Here you pay only 1,000 rupees and you barge into your chamber, I can barge into your chamber and I can assault you also. You know, for not satisfying.
I understand, yes, I get your point.
But the fact is that human life is very important and suggestion is also very important.
Yes.
I like your presentation only because you said, you talked about those robot machines and you specifically you pointed out that this machine is better and that machine is better and this is the advantage.
So, thank you so much.
Friends, it's 10:24 and we have 6 minutes for Dr. Tulsi and Dr. Kalra sir.
Sir. Yeah, sir. I'm very much delighted that you mentioned about Sushrut. Sushrut, who imagined something which is now possible as robotics. It was not possible there. And I'm also delighted that Krishna Chandra, a writer, a novelist, had imagined robots with emotions some 100 years back. Can you imagine? 100 years back he imagined robots with emotions. So we are yet to achieve that. So I'm delighted that we are moving towards robots and they are becoming, as you said, gold standards now. So, about the drone in the field of army, and they are doing drones intervention. So robots is like drones. You are sitting somewhere else, you are operating without any more complications. Your comment about drones versus robots.
So, the robots that we have are still not wireless. The surgeon has to be connected to the main machine, but then there have been trials. For example, a surgeon was sitting in the US operating in Europe through wireless technology. So I think it will come in the next 5 years. The drone technology is going to come in.
It's also in the pipeline.
Yes. So next 5 years.
Distant surgery.
Yeah.
Thank you so much.
Very good.
Okay, Dr. Shah.
Sir.
Great talk.
Thank you.
So robots have become the standard of care in radical prostatectomies.
Yes.
Partial nephrectomies for small tumors.
Yes.
And of course radical cystectomies as well.
Yes.
So in 2003, less than 1% of the RARPs were done in US. Today more than 90% of the RARPs are done today. So I think totally we find that recovery of continence is earlier in the robotic group, but at 1 year there is no major difference for urinary or sexual functions. What do you say about that?
That's not true.
That's not true.
That's not true. There's only a minor set of studies,
Yes.
probably with some hidden interest in the investigators, that they've shown that at 1 year it's the same. It cannot be the same. So,
Right.
I've seen a lot of patients with open surgery being incontinent for 5 years, but zero potency. So obviously it's logical. You see every nerve, you save it.
Absolutely.
Magnified vision.
So precise that you can probably conserve that.
In open surgery, the 2 surgeries that I did, I couldn't see anything. I just put my hand in and took out the prostate. I don't know what I'm removing, urethra or the nerves or whatever.
Right.
That's the difference.
So what about the future robots? See, tactile feedback already there now?
Yes, absolutely. So the 2 things that I think, 3 things. One is the wireless technology, second is the tactile feel. Right now when I touch the prostate, I don't get any feel, obviously because the machine is touching, I'm sitting at a distance.
Yes.
The tactile feel is one thing, and the third thing is the robot guides me as to where to cut. It amalgamates the CT and the MRI images with the real-time image. And if I'm going to cut on the bladder and not on the prostate, it will stop and tell me you're cutting at the wrong place because the CT shows that the prostate is there and not here. So that is the 3D amalgamation with AI that's coming.
With artificial intelligence. Thank you, sir.
So thanks, it was so nice.
Thank you.
I'm a sexologist.
Right.
There are a number of patients who come to me with erectile dysfunction. My question is that if a patient is young, if he is in 30s and he is having prostate, so what will be your call? Will you go?
Generally, to answer that, I have never seen a patient of 30 years for prostate cancer. It's generally after 50. Some patients in the 40s, yes, can have it if they have a strong family history. Depending on the treatment options available, it's either surgery or hormones and radiotherapy. Hormones and radiotherapy would cause the same or even more erectile dysfunction. Now with the robot coming in, I can be assured that I can save his nerves and his erectile functions can be better. Between open surgery and hormone and radiotherapy, I would have suggested hormones and radiotherapy for a young male because open surgery 100% will always be important.
So two patients, a patient 45 years old, having two children, family complete, he comes with prostate, definitely you will go for the surgery.
Yeah.
Second patient, a patient 52 years old, unmarried, and he wants to continue with his family, he wants to marry. So what will be your call?
So if he wants to, first I would counsel him for sperm preservation, preserve his sperms, and then can go ahead because radiation and hormone therapy will also make him impotent and infertile. Surgery, irreversible. I cut the seminal vesicles and take it out with the prostate, so he's forever infertile. Radiation and chemotherapy and hormone therapy for a long time, he will be impotent, but that is reversible. So probably I will suggest him sperm preservation and hormones and radiotherapy.
Last question, sir. Da Vinci. This is an American company.
This is an American Intuitive in California.
They are in Hollywood filmmaking.
How is it good?
No, yes.
Achha, okay, I know.
Yes. This is the only one company, which had made all the Hollywood films. So this software, yes, Da Vinci. Da Vinci Studio.
No, the company is not Da Vinci. The company is Intuitive.
Yeah, but the software is Da Vinci.
Yeah.
They are in इनका जो पहले जो सॉफ्टवेयर लगता था वो तकरीबन 45 करोड़ का लगता था
ओके
तो दे वाज गुड बट नाउ दे हैव अब बहुत सस्ता हो गया
जी
बट दे आर द बेस्ट एंड मैं आपसे रिक्वेस्ट करता हूँ सर अगर आपको कभी मौका मिलता है तो इस कंपनी का सॉफ्टवेयर यूज करेगा दे आर द बेस्ट
ओके थैंक यू फॉर दैट इन्फॉर्मेशन थैंक यू
Last question.
Sir.
I'm a GP.
Sir.
Very simple question. If a patient comes to me with a total PSA, and it is just marginally high.
Marginally high.
And what stage we should tell him to go ahead for the...
So repeat the PSA in 4 weeks time.
Okay.
If it stays high or is rising, get an MRI done.
Get an MRI.
If it's falling down, it's fine. There's nothing, it probably was prostatitis or UTI. But a repeat PSA and MRI if the PSA keeps rising.
After 4 months?
4 weeks. 4 weeks.
After 4 weeks?
4 weeks, yes. Okay, thank you, sir.
I would request Dr. S.K. Podar sir to summarize the second CME for us. The first CME has been taken care of by Dr. Viveka, so we are not going to bother Dr. S.K.
I think in the last question, raised PSA, you can give a course of antibiotics if you suspect infection, then you can repeat after 4 weeks. So thank you, Dr. Tushar. We lost two main advantages of open surgery, laparoscopic surgery, tactile sensation and 3D vision. So in robotic, we have regained 3D vision, but tactile sensation we still have to regain. So, but in 3D vision we have regained. So thank you for giving very informative lecture. I think robotic surgery became very popular only in case of carcinoma prostate. Initially it became very popular because it was working in the depth where the human hands can't go in open, even laparoscope can't go. And then partial nephrectomy, nephron sparing surgery, I think local robotics is well established. Thank you very much. Thank you. You keep coming in our forum.